All right, let's just dive into it. So we are talking about hypertensive medications, all right? So the first thing you would want to do is what's called monotherapy, which means we start with one drug. There are 4 classes of medication that we're going to use for monotherapy. It's going to be the thiazide diuretics, the calcium channel blockers, the angiotensin converting enzyme inhibitors, the ACE inhibitors, and the ARBs, the angiotensin 2 receptor blockers, okay? The first one we're gonna talk about is here in the orange. This would be the thiazides, okay? So, what is the mechanism of action for the, sorry, it's in the blue, not the orange. What's the mechanism of action for thiazide diuretics? So they're diuretics which make you think kidney. They're going to prevent the sodium reabsorption in the distal tubule of the kidney, okay? If we prevent sodium reabsorption, that's going to keep sodium in the distal tubule, that's going to keep water in that tubule, and that's going to push more fluid out of the body, which is great. It's going to lower our blood volume, cardiac output, stroke volume. Good, it's going to cause hypotension. It's going to fix our hypertension, okay? Examples of thiazide diuretics, HDTZ, our hydrochlorothiazide, and our chlorthalidone thalatone. Okay, those are our 2 diuretics. Now, side effects of this, obviously salt is going down, so hyponatremia, but potassium's going down as well, hypokalemia. So just remember, 2 things are going down, 2 things are going up, sort of. We're gonna have hypercalcemia, so calcium I think is a larger molecule, but it's going up. And then hyperglycemia, which is kind of not true. It's just we have less fluid in the body, so the sugar that's in our blood is less diluted, okay? Side effects of thiazide diuretic, let's think of like contraindications. The only contraindication here is I can't pee, okay? And side effects would be, I think just hypotension. Anything else here? Well, we already mentioned the side effects with the electrolytes that went down. That's it. That's thiazide diuretics, easy. All right, we are gonna move on to calcium channel blockers. So slightly more involved here, but not too bad. Calcium channel blockers, this is all about smooth muscle. It prevents calcium ions from being excreted into muscle, so it's going to be a vasodilator. That's what calcium channels are. They're a vasodilator. All right. Examples of calcium channel blockers. There are 2 kinds. There are the dihydropyridines and there are the non-dihydropyridines. We're gonna first talk about the dihydropyridines because these are just vasodilators. Okay, examples of these would be, these are the dihydropyridines, so not as bad. This is our amlodipine Norvasc. This is our nicardipine Cardine, and our nifedipine Procardia. So these are our dihydropyridine calcium channel blockers, okay? This is really difficult to remember all of this. Side effects of this are, I don't remember, I'm kind of blanking out on some of this. Let's go to the, at least I can name the examples of the non-dihydropyridines. This would be verapamil, Verilan, and this would be diltiazem, cardizem. Not only are these going to be vasodilators, but these also have some chronotropic and I think dromotropic characteristics as well. So if you have left ventricular dysfunction, if you're having some issues with your ejection fraction, you're having systolic heart failure, do not take a non-dihydropyridine calcium channel blocker because it's going to it's going to weaken your heart even more. And we really don't want to do that, okay? So that's a big contraindication for calcium channel blockers. Now, calcium channel blockers are great for the African American patient, okay? That's, I think, milk and water, so actually thiazide is preferred too. So that's something to keep in mind. I'm trying to think of what else could be going on. Calcium channel blocker. Let's kind of cheat a little bit and look here. So we got most of this. Side effects are just hypotension and edema of that first one. So I kind of think like vasodilation is almost like pushing fluid back into like the systemic or like the intracellular space, I guess. I don't know if that's the reason, but that's what I think of. You can also think of your dihydropyridines as your pines, your pine trees. That's your amlodipine norvasc. That's your nicardipine cardine, and that's your nifedipine procardia. So all your pines, all your pine trees, that's your less severe calcium channel blocker, okay? The other thing to keep in mind, and this makes a lot of sense when you think about it, is the non-dihydropyridines, again, the more severe ones, which are verapamil, Verilan, and diltiazem, cardizem, they're going to cause bradycardia. Because remember that I think it's both electric, chronotropic and dromotropic. Yes, your SA node and your AV node conduction is being reduced. So if you already have bradycardia, your heart rate's going to drop. So do not give this, okay? Again, like I said, heart failure as well. You don't want to weaken the heart more. So you're not going to want to give these non-dihydropyridines. And that's pretty much it. So those actually aren't too bad. So we are going to move on to maybe my personal favorite. I don't know, trying to make this stuff exciting. These are the ACE inhibitors. Okay, these are your prils. This is your lisinopril, which is Prinavil or Zestril. This is your Ramipril, which is your Altase. This is your Enalapril, which is Vasotec, and another name. And this is your Quinapril, which is Acupril. Just to give you some examples, there's also Benazepril, which is low tensin. So all your prils here. So what does an ACE inhibitor do? So you have to think about the renin-aldosterone angiotensin cycle? That doesn't make any sense. But you have to think about RAS, you have to think about the kidney, you have to think about renin, going from angiotensin 1 to angiotensin 2. ACE, which is the angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2, is being inhibited. That's why it's called an ACE inhibitor. The big contraindication here is pregnancy. Do not give this to somebody who is pregnant. This is teratogenic, I think is the term. Okay, so what is this going to cause? I think of my brother sitting on a table and he's swelling up. This causes angioedema, okay? This causes hyperkalemia. I think about a big stack of bananas sitting on a desk, okay? So it's going to cause hyperkalemia. So if you already have hyperkalemia, don't give somebody an ACE inhibitor. It's also going to cause like some renal dysfunction as well, and it's going to cause a cough. It's thought to be the reason for this cough is that ACE, the angiotensin converting enzyme, which we are inhibiting, ACE itself inhibits bradykinin. Bradykinin is a vasodilator. All it wants to do is like help out the heart and vasodilate. So that's a good thing that we're knocking out ACE and allowing bradykinin to do its thing, but it's thought that these kinins might cause this swelling and edema, might cause this coughing, okay? Real quick with the cough, more common in women. This can take, for everybody, weeks to months to develop. It's more common in the Chinese population, and that's pretty much it. So that's ACE inhibitors. So all in all, it's a vasodilator because it's knocking off angiotensin 2. Angiotensin 2 is like the blood pressure king. It's causing vasoconstriction. So we're knocking that off. Normally, angiotensin 2 would continue to the adrenal cortex, which I have kind of up here in the brown, which would secrete aldosterone, which keeps aldose salt, so volume is going up, and the antidiuretic hormone, which again, antidiuretic keeps fluids. So if we're inhibiting both of those things, fluid is coming, there's vasodilation, which is great. That's what we want for an ACE inhibitor. What else am I missing here? Yeah, so I mentioned that side effect of like kidney issues. So if my kidneys already suck, if I'm in like renal failure, don't give this. If my potassium's already high, don't give this. This can cause a rash as well, okay? So that is a good reason to give this. And there's the CHAB mnemonic, which is controls hypertension and diabetes. If you have a diabetic, this is great. If they're in heart failure, this is great. And if they had an MI, this is great as well, okay? So ACE inhibitors are generally a good medication. Okay, so with that, a related medication is going to be the angiotensin II receptor blocker. You would give this if an ACE inhibitor is contraindicated. So if your patient has hyperkalemia, but mainly it's the cough. If your patient can't tolerate the cough that they're getting from the ACE inhibitor, give them an ARB. These are the sartans. This is your losartan, your Cozar. This is your olmesartan, your Benicar. This is your telmisartan, which is your Micardis. And this is your, any other sartans here? I'm sure there is something I'm missing. Your valsartan, which is your Diovan. Okay, these are your sartans. So let's think about this for a second. Side effects, I believe, are similar. I think you still do get angioedema. You still technically can even get a cough, but it just doesn't happen as much, okay? Bradykinin is blocked again. Okay, but again, this is the angiotensin II receptor blocker, so we're kind of going right to the source. So ACE still does its thing. There's still angiotensin II that exists, but once it gets to the receptor, it's blocked. It's not able to do its thing, okay? Again, the big contraindication here is pregnancy. Similar side effects. We can also get a rash, and also it can cause hyperkalemia, all right? Okay, so there we go. We also have irbesartan, which is Avapro. So again, just another sartan. There's also candesartan, which is Atacand. So we do have some, quite a lot of the sartans here. Okay, let's go on to beta blockers. This is a big one. This is very, very involved because there are 3 classes here. Okay. The first one that I like to talk about are technically the second generation. Now, what does a beta blocker do in general? It inhibits the beta 1 receptors, okay? They're beta 1 blockers. What does beta 1 do? We have one heart. It helps contract the heart. So a beta blocker is going to ease the contraction on the heart. Now, what is this good for? If I've recently had an MI and my muscle is weakened, which I guess is kind of like not what you would think you would want to do. In general, these are not your first line medications. Remember, if I had an MI or heart failure, ACE inhibitors are kind of the way to go. All right. I think sometimes people are on an ACE and a beta blocker potentially, but this is good if I had an MI, if I'm in stable heart failure, or if I have asymptomatic left ventricular dysfunction. So when we're talking about the calcium channel blockers with that negative chronotropy and that negative dromotropy, we're not affecting the kind of electrical part of this. We don't want to give that to somebody who has that left ventricular dysfunction, but a beta blocker is okay as long as they're asymptomatic, okay? There actually is still some negative inotropy, chronotropy here, so I'm not really sure why that is. But just keep in mind, these are not first line, and if they have heart issues, but they're sort of stable, you can give this to them. Okay, let's go back to some examples. So, second generation, these are the new ones. They're better and they're new because they are selective. They only affect beta 1. Okay, so they're only going to affect kind of like the contractility of the heart. The mnemonic for these is BEAM, okay? So that these are selective. It's a focused beam of light, which I drew here in this alien picture. This is your bisoprolol, which is beta. This is your, I don't remember the E one. I'll get back to that in a second. A is atenolol, which is tenormin, which I don't think technically was on his slide. And then we have metoprolol, which is low pressor. The E is esmolol, okay? So again, these are focused. They only do beta 1. And we'll get to contraindications in a second, because and side effects in a second, because that's kind of the same for everybody. Okay, so now we're going to move on to the non-selective beta blockers. These were the old schoolers. I think of an old school like PS 118 from Hey Arnold. That's a public school. Propranolol, which is Inderol, and Sotalol, which is beta pace. These are non-selective, meaning not only are we affecting alpha 1, but now we are affecting beta 1 as well. And, right? Alpha 1 and beta 1? No, I'm sorry. Back up for a second. Not only are we affecting beta 1, but now we're affecting beta 2. And this is the important thing. Beta 2 means we have 2 lungs. So this is going to affect respiratory as well. And you don't want to give this to somebody who has COPD, who has lung issues, okay? So these are going to be, and beta 2, I'm pretty sure probably has some cardiac stuff involved as well, and like some other things. But it's going to be a little bit stronger. It's non-selective, so we're hitting 2 things. So if you have COPD, you don't want to give this to somebody, all right? I also want to look at, I don't know that I actually looked at big contraindications for betas. Oh, heart block. That's in the red. Okay. We don't want to give this to somebody who has heart block, and that's really the only big contraindication for beta blockers. Okay. Which I guess makes sense. Okay. The last kind of beta blocker, these are combos. So we're still going to have the beta 1, but now we're going to have, this is where we get the alpha 1. Alpha 1 is a vasodilator. So beta, we're having the negative inotropy and chronotropy. So we're having that electrical contraction, inhibition. But now we're having vasodilation as well. So this is going to be even stronger. I call these the renegades. This is your labetalol, which is your normandine and trandate. And this is your doxazosin, Cardora, and your terazosin, Hytrin. Right? Am I getting this right? No. Oh my God, that's totally not right. Those are alpha blockers. These are there's just 2 of these. This is labetalol, which is normandine trandate, and carvedilol, which is Coreg. These are your alpha beta combos. So they're beta blockers, but they also have alpha 1 as well, which is where we get that vasodilation. So these are going to be important. A side effect of all of these beta blockers is bradycardia, which makes sense because we are inhibiting that beta 1 receptor, okay? So heart rate is going to go down, which is going to overall drop our blood pressure. So there's going to be some dizziness here. There's some new side effects kind of compared to all the other ones, which is decreased sex drive. We also have some nausea and diarrhea, okay? So those are our big contra up here is heart block for all of these. And again, it's second line. So if they come in with hypertension, we're not going to start them on a beta blocker right away. And we really want to think about, do we want to go focused? Do we want to hit it a little bit harder, but be careful with COPD? Or do we want to add some vasodilation as well? Which if they're on like a calcium channel blocker or an ACE inhibitor, they're already kind of vasodilated. So kind of complex here, but that's kind of the main idea. All right, so now we're going to move on to alpha blockers. Again, these are also not first line. These are the ones I was talking about with the doxazosin Cardora, the Hytrin, which is terazosin, and then the prazosin, which is mini-pres. So these are, alpha-1 is really just a vasodilator, similar side effects to beta blockers, decreased sex drive, but now we're adding in erectile dysfunction and priapism, still some dizziness and some syncope here as well. So just know that these exist. I don't think he went into detail of why you would use an alpha over a beta. So just kind of know that those are there. There's another type of alpha medication. This is an alpha-2 agonist, and this is clonidine. This is clonidine and catapres, okay? So this is an alpha-2 agonist. I think of like two cool cats in agony, so two alpha cats, so alpha-2, okay? The last of the blood pressure medications is hydralazine. This one is not too crazy. The specific thing about this one is that it's an arterial dilator. So I think about the two A's in hydralazine, it's an arterial dilator. The contraindications here are if I already have a coronary artery disease and if I have a mitral valve disease. That's the only detail he went in. So, good Lord, that's all of the hypertensive medications. How fun.